It is my pleasure to introduce our speaker today at the noon conference, Dr. Klister Balderrama. She received her medical education from Medical College of Wisconsin. She also completed her residency and fellowship at Medical College of Wisconsin. She is board certified in rheumatology and internal medicine by Medical Board of Internal Medicine, and she's been with Technician since 2016, working here at the clinic.
Well, thank you all for coming this afternoon. I hope you can all get a little bit of something out of this, no matter what your specialty or interest is. I've been compiling sort of a list of things over the last several months since I was asked to give this that I thought could be useful, and have whittled it down to these things. I'm going to start with some cases focusing on different presentations, pattern recognition of arthritis, inflammatory and non-inflammatory etiologies. And then I also wanted to focus on polymyalgia rheumatica and gout, because they're such common things that you certainly will see no matter what you do, I think. And as a rheumatologist, of course, I have to touch on ANA testing again, and if we have time, I'll do a little bit of osteoarthritis management as well. So just to start off, I've been here a little over 2 years now, and I'm trying to shore up my practice and make things a little more efficient. So I'm trying to really focus in on inflammatory and autoimmune conditions to try to keep access open to me, so that those patients that I can make the biggest difference in treating and managing can get into me in a timely fashion. And that's not really anything unique. That's what we were doing at Froedtert all these years, and it's also something that's been studied. This is wordy, but this was a university study looking at about 1,000 rheumatology referrals. They ended up seeing about 2/3 of the patients and declining, fibromyalgia, osteoarthritis, back pain, management of those sorts of things. And in doing that, they were able to keep their wait times to about 2 weeks. They were also able to open up more than 200 new patient slots a year in doing that. And in saying that, arthritis is my specialty. I can't see everybody with joint pain, but I am more than happy that if you have a patient that doesn't seem right, that you just start looking for something else, any other ideas what to do, by all means send me a message. I'm more than happy to try to assist with that. They just may not need a consult in person. So to start off, I kind of wanted to go through how I think of each consult that I see when it's a joint-based consult. As with anything that comes to your office, the most important thing is getting a good history and a good physical exam. Labs and imaging can be helpful in steering you in one direction or another, but the history and physical is going to be most of your information. From there, I'm looking at, is this a joint-based issue? Is this a periarticular problem? Is it a bursa? Is it a tendon? Is it non-inflammatory or inflammatory? Those features, whether it's joint-based or not, and whether it's inflammatory or not, are going to be the main things that you need to know in deciding what to do next and how to treat it. And then getting to the nitty-gritty of things, I'm looking at other patterns, and we'll go through this mainly in looking at cases. But is it symmetric? How long has this been going on? Is it an acute or a chronic process? Which joints are involved? How many joints? And other features, the age of the patient, their gender, things that would lead you in one direction or another. So I'm using the example of the elbow here because there's not too many things that I needed to go through. So for starters, just looking at the range of motion of the joint that the patient has, if they can fully straighten and bend the joint, we're probably not talking about an arthritis problem. If passive range of motion, I should say, we're probably not talking an arthritis problem. If with active testing and some more specific maneuvers you're eliciting pain, would be more suggestive of a tendon. All of these things that I sort of pictured here, tennis elbow, olecranon bursitis, all of these things are going to come to you with the chief complaint of elbow pain. But really, this patient who can't fully straighten his arm would be the one that I'd be most concerned about arthritis. Palpating the joint, are there focal points of tenderness? And again, to me, that can be suggestive of a periarticular non-arthritis issue. Is it inflammatory or not? The hallmark features of inflammation have always been warmth, swelling, erythema, which may or may not always be present. And I was always taught, use the back of your hand. It's the most sensitive way to detect temperature differences. Feel, around the joint. If you're going down the arm and all of a sudden the elbow is warm and hot and it's cool on the other side, that's suggestive of inflammation. Compare it to the temperature of the joint on the other side. And ultimately, this would be the step that would get to me, where I'm going to aspirate the joint. If there's fluid there, you can prove whether it's inflammatory or not. Other questions that can help lead you down a different inflammatory or mechanical path. Morning stiffness. We use that cutoff of an hour of being suggestive of inflammatory joint pain. That's not always the case. You'll hear in your fibromyalgia patients, they're stiff all day. Sometimes osteoarthritis stiffness can last that long too. Other systemic symptoms, fatigue, rashes, other things that could suggest an inflammatory condition. And I always ask the question of does being active doing your day-to-day stuff, do you feel better with that, or does that make things worse? Feeling worse throughout the day in terms of joint pain is often suggestive of osteoarthritis. I'm going to show you a couple of slides with a whole bunch of stuff, too much to absorb, but then we'll kind of go through cases and try to work through this individually. So the hallmark symmetrical inflammatory condition that always needs to come to mind is going to be rheumatoid arthritis. Other things that you would consider based on the age of your patient, for example, in an older patient that may be polymyalgia rheumatica. If they are a young patient with other symptoms, I would hone in on connective tissue diseases. The classically asymmetric inflammatory conditions would be the spondyloarthritis type conditions, so the psoriatic arthritis, reactive arthritis, ankylosing spondylitis, and then just one other one that we'll focus in on, but again, asymmetric inflammatory, but the crystal arthritis, so gout and CPPD, or pseudo-gout as it's better known. This chart, I can't tell you how many times I've referenced this chart still and throughout fellowship, but just in creating a differential based on what joint is involved. What can also be helpful too is just looking at what joints are not involved. For example, if you look at osteoarthritis here, red flags would be if a patient is telling me joints that typically aren't involved in osteoarthritis. So, the MCPs, the wrists, the elbows, the shoulders, ankles. Unless somebody's had injury or damage to that joint, those are not normal joints to be involved in osteoarthritis. The same thing goes for rheumatoid arthritis. This is a small joint predominant arthritis, and it's not something that affects the back or the DIPs. So I'm looking for joints that are involved and joints that aren't involved, and trying to figure out what kind of arthritis a person has. Looking specifically at the hands, for example, rheumatoid arthritis, CPPD, the MCPs are commonly involving those. Osteoarthritis, unless somebody has a repetitive job or certain things that would predispose them to damage to those joints, it shouldn't be involved in osteoarthritis. Osteoarthritis, on the other hand, the PIPs and the DIPs are the characteristic joints involved in that. The thumb joints, the CMC joint, the MCP even on the thumb can be involved. And then this is where we'll talk more about age, but the MCPs are involved in a limited subset of different kinds of arthritis. In young or old patients, I could consider rheumatoid arthritis, and in the elderly, CPPD could also be a very reasonable diagnosis in a patient of that age. One more little picture that I included on here is the patient with psoriatic arthritis. Probably you could tell that from the nail changes, but this patient has dactylitis involving several of the fingers. There's not a lot of kinds of arthritis that give you, a sausage digit like that, so I'm always honing in on spondyloarthritis, and gout can sometimes give you a picture like that too. So I threw a lot of information, a lot of tables and stuff on there, so I'm going to go through 6 cases here, just focusing in on a couple of those features that I had highlighted. So this is a 20-year-old female who has a 4-month history of pain and stiffness in her MCPs and her wrists. Her symptoms are worse in the morning, they last for an hour, and they improve with movement, so I'm getting you clues that this is an inflammatory arthritis. She's fatigued, but she otherwise doesn't have any other symptoms of concern on her review systems. And on exam, her wrists are slightly swollen and tender, her MCPs are tender but not swollen. And the question here is, what do I want you to order? What do I not think you need to order? So in her, we're talking about a chronic and symmetric arthritis involving the small joints. The leading thing that I would think of in the absence of any other systemic symptoms would be rheumatoid arthritis. And I'd want to see you order both a rheumatoid factor and CCP antibodies. The arthritis panel that's available to us on the lab, I really don't like that panel. It's such a smattering of tests. If you would order that and you get a uric acid, a gout in a premenopausal young female shouldn't be on your differential. small joint arthritis, I wouldn't be highly suspicious of Lyme, which is also on that panel, and you're only going to get a rheumatoid factor. So think about what diagnosis you're going with and order the appropriate test. The CCP antibody, for example, is positive in about 15% of patients who don't have a positive rheumatoid factor, and it's even more specific for rheumatoid arthritis than the rheumatoid factor is. I would get x-rays of her hands too in this patient, and I probably wouldn't order an ANA because she's not otherwise giving us symptoms to suggest lupus. And a lot of these patients with rheumatoid arthritis will have a weekly positive ANA, but it might just lead you down the wrong track. So other things in the differential that I would consider, as I was just mentioning, if she had told me she's getting rashes, sores in her mouth, I would absolutely check an ANA. If she was an older patient, so if this was an 80-year-old female and she's giving me a 4-month history of swelling in the MCPs, I would consider pseudo-gout, and maybe you'd get some clues on the x-rays that you ordered if she has some calcium deposits on the x-rays. Polymyalgia rheumatica, again, something that you consider in somebody who's elderly. So case 2, this is a 26-year-old female, again, with diffuse polyarthralgias. Only in this case, she's had symptoms for only a week, not 4 months like our last case. And at the onset of her symptoms, she had flu-like illness, joint pain, low-grade fever, and a rash on her face that resolved a couple days ago. Her joints continue to hurt, especially her fingers, her wrists, her feet, and she otherwise doesn't have any remarkable past medical history. She's a 3rd-grade teacher. She doesn't smoke, drink, she's not sexually active. Her vitals are normal, and on exam, she has tenderness over multiple small joints of the MCPs and PIPs. She's got some swelling in the wrists and small bilateral knee effusions. And this is a picture of her hands with swelling. So your differential for acute polyarthritis is going to be different, and it's going to include a lot of infectious etiologies. It is not uncommon in viral illnesses to see an acute inflammatory arthritis. She doesn't seem quite sick enough to suggest anything bacterial, and given all the joints involved, that wouldn't be high on my list. She is a 3rd-grade teacher, so you're thinking of her being exposed to all the things that kids carry. It wouldn't be unreasonable, to consider things like rheumatoid arthritis, but a sudden onset presentation with all this other systemic stuff that was described here is probably not the scenario. Most of these other conditions, rheumatoid, lupus, psoriatic arthritis, reactive, are going to build slowly. It's less common to see them just be aggressive right out the gate. Case 3, a 45-year-old female with hand pain. She notes that her wedding ring doesn't fit anymore. She works as a butcher, and her pain worsens throughout the workday, so sort of the clues that we're honing in on for non-inflammatory arthritis. She notes that her hands can feel numb at times, especially in the morning, and that her hands are starting to look like her grandmother's. I hear that line a lot. She doesn't have any other notable features on her review systems, and on your exam you notice that she really has bony enlargement of the PIPs and the DIPs, so the classic joint distribution for osteoarthritis. There's some tenderness of those joints, but there's no synovitis. And on exam, osteoarthritis, I remind people at times, it can really be deforming and it can look impressive as it does in these cases. But if you palpate these joints individually, they shouldn't be squishy like synovitis. They should be bony. And that's another thing too when people are telling me their family history. Well, my grandmother had really, deformed hands. That could be osteoarthritis. These are impressive deformities too. Case 4, so this will be a monoarthritis. This is an 86-year-old female with a 4-day history of pneumonia who's admitted currently. And during the course of her admission, she develops a swollen right wrist. You get an x-ray of her hand, and a notable feature, which maybe doesn't show up too well on here, is that she does have quite dense calcification in the triangular fiber cartilage here. Her wrist is mildly warm and tender, and her pneumonia is improving. She's otherwise feeling better. She'd like to go home. What would you do next? So the two things I think that always need to come to mind when you are thinking of a monoarthritis is infection and crystal arthritis. Those are the most common scenarios and the things that I'd like you to think of in your primary care clinic, if that's where you are. For somebody like this who's feeling better, who's not really systemically ill, and who has an x-ray like that, I would favor a crystal arthritis like pseudo-gout. That's a diagnosis that, to me, when I get this as a consult, it always comes to me as gout, but if you look at the imaging, you see the calcium. This is a woman, this is her wrist. She's 86 years old. She doesn't have any impressive, kidney dysfunction. Pseudo-gout, I think, is often under-recognized, and it's maybe even more common than gout. It favors the involvement in the knees and the wrists, and it's not uncommon that you see patients with crystal arthritis, gout, or pseudo-gout that they have flares during any other time of medical stress, so hospitalization is a very common time when this comes up. But always keep infection on your differential. You certainly can have more than one process happening at a time. Two more cases. So this one, just to drive home that point of more than one thing happening at a time. This is a 65-year-old with a history of high blood pressure, obesity, osteoarthritis, and he's got a 2-day history of acute right knee pain and swelling. And at this point now, he's having difficulty walking and he's needing to use a cane. He does have a longer standing history of arthritis in the right knee, and he recently returned from a trip to Greece where he was walking more than he usually did. During that time, he was sick with 2 days of diarrhea. That's gotten better. And at this point, it's really just his right knee bothering him. He's not having fevers or chills, but his knee pain is keeping him up at night. And on exam, he's got a low-grade temperature, 100. Vitals are otherwise fine. He's got osteoarthritis changes in his hands, and his right knee is warm, swollen, and painful with range of motion. Nothing else impressive for swelling in other joints. The notable features on his exam, he does have a little bit of a white blood cell count. His SED rate is elevated at 65, and a uric acid was checked, which was 6.5, mildly elevated. And X-ray of his knee, he's got osteoarthritis changes. They're kind of leading you to think, well, maybe is this pseudo-gout because he's got this dense, again, chondrocalcinosis changes. What would you do with this knee? In this scenario, it's got to be aspirated. If he had told me, if I was examining him and this knee is cool and he doesn't have any other symptoms of systemic inflammation with his history of osteoarthritis, it's probably just a flare of that. But this knee is warm. He was recently sick with something presumably bacterial, and I would really rely on that cell count to help guide me in what I'm going to do. It would never be a wrong answer to cover somebody like this as bacterial arthritis, even if you found that he had gout crystals or pseudo-gout crystals, until you're sure, because it could have two things happening at once. And finally, last case for this. This is a 22-year-old male, previously healthy. He had a bout of unilateral uveitis that was successfully treated with topical steroids. 2 months after that, he develops inflammatory sounding back pain, worse at night and in the morning, and improves during the day with activity. 3 months later, he develops acute onset of left knee pain and swelling and prolonged stiffness in that joint. He also describes chest wall pain with inspiration, pain in his bilateral heels. He doesn't give you any symptoms to suggest that he has psoriasis or inflammatory bowel disease, but he does have an uncle with Crohn's disease. And on exam, he has chest wall tenderness. He's got a moderate-sized knee effusion that's warm, and he has point tenderness over the left Achilles. So in this patient, we're talking about a chronic arthritis. We're talking about asymmetry with a lower extremity predominance, and other clues that are given are tendinitis, so enthesitis involving the heel, and uveitis, which are things commonly seen in the spondyloarthritis. And so he'd probably fall in the undifferentiated spondyloarthritis. He doesn't have Crohn's disease personally. He doesn't have psoriasis, but he's probably HLA-B27 positive. So to summarize that whole blurb there, acute monoarthritis should always be aspirated. In crystal arthritis and infection are the things I want you to think about. For a chronic symmetric synovitis involving the small joints, rheumatoid arthritis is what I would think of. Make sure you check the rheumatoid factor and the CCP antibodies. And for an asymmetric, large joint predominant arthritis, spondyloarthritis, and I didn't really emphasize this too much, but dactylitis, limited differential, we're talking spondyloarthritis or maybe gout. So moving on to polymyalgia rheumatica, you're definitely going to see this at some point. It affects about 2% of the population, so it's one of the most common things that you would see in a rheumatology clinic. There's increased frequency with age, and it's not something that you should consider in patients who are younger than the age of 50. The odds that somebody has this increases with age, and the mean age of onset is 70 years old. It's slightly more common in women than men. The shoulders are affected in pretty much everybody and tend to be the first area affected, even in patients who develop neck and pelvic girdle symptoms. It's uncommon to just have isolated pelvic girdle symptoms. And this is also a condition that is exceedingly symmetric. So if you have a patient who comes in with just right shoulder pain, if they don't quickly develop symptoms involving the other joint, I would be thinking of other things. And really, the physical findings in these patients tend to be really underwhelming for what they describe. I mean, patients describe, disabling, dramatic, severe symptoms. Their energy level is poor. They usually, if I read the nursing notes on a referral from this beforehand, it oozes PMR, and you see them and they look pretty fine until you ask them to move their joints. So their joints feel worse with any rotation. They usually can't get their arms up above their shoulder level. Usually before I even get into things with people, I ask, can you bring your arms up over your head? And if they can do that, we got to talk about something else besides PMR. Morning stiffness is a really pronounced symptom of this as well. Nighttime pain that awakens the patient and is prominent in the early hours of the morning, and difficulty getting up from a chair or lifting the arms overhead. A lot of patients with this will complain of weakness, but they shouldn't be objectively weak on exam. If that's the case, then you need to think about a myopathic type process. And associated symptoms, so fatigue, weight loss, low-grade temperatures, depression is also not uncommon. If you're talking about dramatic weight loss, drenching night sweats, high-grade fevers, those, again, would be other signs that we should look for something else, maybe an underlying vasculitis, so temporal arteritis being one thing, or malignancy as another. So this is from Up to Date, but this is a guy who came in with, I think, a couple weeks of symptoms, can't get out of bed, can't lift his arms overhead, and the next picture is him on 15 milligrams of prednisone a couple days later. So it feels quite miraculous to get this right when you give them that little bit of prednisone, because a lot of these people feel like their world is ending. I hear people say, I thought this is what it's going to be like to be old, and this is, all of a sudden, this is old age, and they do this and they feel back to their normal self, and it's such a good feeling. This is not always as straightforward as I'd like to think that it is. About 50% of these patients will get peripheral joint symptoms. Commonly, they can get knee effusions, they can get swelling in the hands, things that can mimic rheumatoid arthritis. So that makes it a little more complicated. There's this other syndrome, which I feel like I've seen more of here in the last 2 years than I ever saw in fellowship, but RS3PE, it can be associated with PMR. It can also be a variant of seronegative rheumatoid arthritis. So a lot of times in these patients, it's just kind of time will tell what develops with their symptoms, and we'll see how they respond to prednisone and being treated as PMR. Other things to consider in your differential would be fibromyalgia. I'd always check a thyroid, TSH in these patients, depression, and as well as mechanical symptoms, frozen shoulder, osteoarthritis in the shoulder. However, you should see a normal ESR in these patients. Other things to consider when you're thinking of more dramatic symptoms, like I said, weight loss, fevers, would be occult infection and malignancy. And then rheumatoid arthritis is always a possibility, and sometimes is what we end up settling in on later as we follow these patients with time. So treatment, this is like I said, the miracle of prednisone in this condition is really quite miraculous to see the turnaround. Most people have a very dramatic response to a low dose of prednisone, like 15 or 20 milligrams a day. Some people, maybe 25% will take a little bit longer to see that maximum effect. Up to 1 to 2 weeks could still be PMR. I typically will start people on that dose of 15 and only bump up to 20 if I need to, if I don't get the total response, and then gradually over the course of a year to 18 months, they should be tapered off of it. I follow the sed rate and the CRP to some degree, not with any reliable measure during that. I'll check it periodically. I'm focused mainly on their symptoms and seeing that they're improving and things aren't worsening as we tapered on the prednisone. If their inflammatory markers don't normalize though, then we do need to consider other things. So is there any reason to suspect giant cell arteritis or another diagnosis? I've been getting better about highlighting this to patients that I might think that you have polymyalgia rheumatica right now, but this is all entirely a clinical diagnosis. You get a couple clues with inflammatory markers, but inflammatory markers are not very specific. And I went to an ACR talk by some guy from Cornell who's a big PMR guy, and he does the same thing. He said, I tell patients, I think you have PMR now. In a year from now, I might be telling you have seronegative rheumatoid arthritis. This is just one of those things. You treat it empirically, and time will tell, how their disease progresses. Because, in the absence of rheumatoid factor CCP antibodies, we're going off of symptoms. And with that being said, older patients who develop late onset rheumatoid arthritis, a lot of times instead of the symmetric small joint synovitis I was honing in on before with you, they can start with large joint involvement first sometimes, and then later develop the small joints. So it's tricky. And to just summarize here again, over 50, and even I'm a little hesitant sometimes in considering this diagnosis in people in their early 50s because it's just not very common. Have to have bilateral shoulder aching. Almost always have elevated inflammatory markers. About 10% of people will not, which makes it tricky. Morning stiffness, and then I would check a rheumatoid factor and a CCP antibody in these patients to just make sure there's nothing else easy that we can figure out. Gout. This condition very much has a strong lower extremity predominance. Almost all patients at some point during the course of their illness will develop arthritis in the first MTP. That is the initial site of involvement in at least half of patients. You can see involvement in the upper extremities, the wrists, the fingers, the elbows, and the shoulder, but those do tend to be less common than the lower extremities. This is the most common inflammatory arthritis in men over the age of 40. It's not a diagnosis that I would consider in any premenopausal woman unless she had significant kidney issues. And it's a diagnosis that's worth considering in all sorts of patients. I mean, even if their uric acid is normal, even if it's an atypical joint, gout can do all sorts of strange things. And one of the points I'd like to drive home is that I wouldn't make this diagnosis based on an elevated uric acid level. You really need to see the crystals to prove this. Only about 15% of patients with hyperuricemia ever develop gout. On the other hand, if they do have drastically elevated uric acid levels, greater than 10, then your odds of developing gout certainly are higher. So up to, like I said, 15% develop gout with hyperuricemia. Most of these patients will have hyperuricemia for something like 20 years before they ever develop gout. So the reasons to treat hyperuricemia without a history of gout or kidney stones would be things like tumor lysis syndrome. Otherwise, it's not indicated. There's no hard and fast guidelines to just simply treat hyperuricemia. There are some things that I don't normally deal with, but I thought I would include in case there was any nephrologist here. But if there's excessive uric acid excretion, then those patients are high risk for stones and should be treated. The first attack of gout for most people is a monoarticular presentation. It's more common in women, actually, later on to present with polyarticular attacks as their first event, but it's still a monoarthritis for most people. As patients go on for years after that first gout attack, and if it goes untreated, you'll see the interval of being asymptomatic will shrink, and they'll get more and more attacks, they'll become more severe, and eventually you can develop just kind of this chronic inflammatory arthritis that you always have some degree of inflammation. And then you'll develop tophi and things like that with it. So these attacks, these attacks are intense. I mean, the women who do experience these attacks often liken it to childbirth. So I believe the men who are very upset about their gout attacks, about how painful it is. These joints are hot, red, swollen. It's not just my toe hurts and my toe hurts all the time. That's not going to be gout. There should be a lot more inflammatory type symptoms to go along with this. The characteristic, textbook type thing would be that they occur overnight or early in the morning. And later attacks, they become more frequent. They start to involve more joints, and the attacks last longer than the couple of days that they initially start as. I have people ask me about diet all the time with the hope of avoiding medicines, but it's important in trying to avoid precipitating an attack, but in terms of treating gout alone, you're at best, if you have a very strict diet excluding purines, you're going to bring down your uric acid by about 1 point, which for most people isn't going to be enough to prevent their gout attacks. So I do recommend avoiding organ meats, seafoods, and certainly for everybody, no matter what their condition is, sodas, fruit juices, energy drinks. Coffee, on the other hand, low-fat dairy products, and tart cherries can reduce the risk of gout. How much alcohol intake a patient takes in, it also certainly correlates with risk of gout. Beer is the biggest culprit, and there's a twofold increase of a gout flare over liquor. And actually, moderate wine drinking, having a glass of wine a day does not worsen anybody's chance of having gout. So people are usually happy to hear that. again, don't rely on that uric acid level to prove that somebody has gout. I'll give it to you if their uric acid level is 14, this is probably gout, but a lot of times you check uric acid during an attack and it's actually low or normal, so I in fact don't even check this during what I think is an attack because it's not very accurate. Ultimately, you want fluid to prove what you've got. Women with gout, as I was mentioning, this is something you're going to see in women who are older after menopause. It's more common to see polyarticular attacks, and you'll frequently see comorbid conditions, that they have hypertension and they're on hydrochlorothiazide, they have some renal insufficiency. And I do tend to see more gout in the fingers and stuff in women, and I think that's probably in part because women tend to have more of the Heberden's and Bouchard's nodes, which can act as sort of a nidus for crystal formation. And this, if you're more of a visual person, I was describing you've got this asymptomatic period of hyperuricemia for up to 20 years. You get a first attack, you get a kind of a reprieve before you get later attacks, and as it goes untreated, there's shorter intervals of symptom-free period, and eventually you just develop just chronic inflammation. And gout can be very destructive, and I think we underemphasize how bad this can be. But it doesn't take severe looking tophi like this to develop really dramatic and ugly looking damage to the bones. So this is something that should be treated aggressively when you do know that a patient has gout. For an acute flare-up, I'd have to say, most of these patients have some underlying kidney disease that makes it impossible to use an NSAID. So for most patients, especially if they have more than one joint involved, my standard reflex is to give them prednisone 30 milligrams for 3 days, 20 for 3 days, 10 for 3 days, and stop. Most people need that long, and then that kind of slow taper gets them through the attack. Most NSAIDs, it doesn't have to be indomethacin, which is the standard sort of drug of choice. Most NSAIDs at full anti-inflammatory doses, so like 500 of naproxen twice a day, can be used to treat a gout attack if the patient's kidney function is normal. Colchicine is only going to be helpful if you have the patient taking it like right away during an initial gout attack. If you try to start it on day 2 of a flare-up, it's just too late, and it's really not going to help. And then as the last thing, the urate-lowering therapy like allopurinol, it should never be started during an acute flare-up. If, however, they're already on allopurinol or Ularic, you would keep it going. You wouldn't stop it. Starting it during a flare-up can lengthen the flare of gout. So indications to start treatment, if they're having more than 2 or 3 attacks during the course of 1 to 2 years, if a patient has 1 attack and they do have really elevated uric acid, I would start it. If they have gout, 1 attack of gout, and they have stage 2 kidney disease, which most of them do, that's kind of another reason to just start it after the first attack. And certainly if they have tophaceous gout, they've had gout for a long time. Allopurinol and Ularic are really the only 2 that I typically use. Again, because probenecid requires that you have normal renal function, it rarely comes up as being an option to use. I would encourage you to start at a low dose and work your way up slowly, and have a treatment goal in mind. It's not enough to just start somebody on allopurinol without treating to target, because if you put them on 300 of allopurinol and you get their uric acid level down to 9, well, they're probably still going to flare at that level, and you need to bring it down to less than 6, or be more aggressive and get them to less than 5 if they have tophi already. And what I will do is I'll start people if they have normal renal function on 100, and I'll put in a standing order for every 2-week uric acid level checks and keep bumping up their dose 100 at a time until we get to that less than 6 mark. I find that allopurinol is really underused in CKD, and that's based on really guidelines that were not based on any evidence. The patients with CKD are the ones who often need the most aggressive treatment with allopurinol, and because of these old concerns, it's not used the way it should be. I would start at a lower dose, so I typically start at 50 milligrams a day, and same as with everybody else, I'll just gradually titrate up every 2 weeks or so. Doses more than 300 can be used as long as you're telling the patient to be aware of things that could happen if they were to have a hypersensitivity syndrome to this, so unexplained fevers, rashes, itching. You can go beyond that 300 mark. When you do start therapy, it does make sense to start prophylaxis. The body doesn't like shifts in uric acid, so you want to have something there to try to prevent a flare-up from occurring. You could use a low-dose NSAID if kidney function is okay. I typically reach for colchicine 0.6 milligrams once or twice a day with a reduced dose if the kidney function isn't good enough. Prophylaxis should typically be continued for at least 3 months because with the shifts in uric acid, they're just still higher risk of flare. If they're still flaring beyond that, I would just keep it running lower. And if you really have no choices for prophylaxis, you can always use a low dose of prednisone too, if need be. And of course, I had a little plug for ANA testing. I wasn't going to include this, but I don't know if any of you get this journal, the Cleveland Clinic Journal. I love this journal. It is so readable. It's just a great journal. And I came across this article, I read it, and it spoke to me. It gave the perfect clinical scenario of the classic patient that I see that comes to me with an ANA. So I sort of summarized this article and I included the patient case that they had. So they give you the case of a 43-year-old female, multiple complaints. She hurts all over. She has swelling in her hands and her feet, morning stiffness, chest pain, shortness of breath, fatigue, weakness, headaches, memory loss. You know, you've seen these patients. Of course, all of her labs are normal except for her ANA, which comes back at a 1 to 320 with a speckled pattern. And she's told she might have lupus, she needs to see a rheumatologist, and during that time she obsessively researches lupus and is convinced that this is the correct diagnosis. So this is a standard day in my life. So when she gets to her room appointment, she has had symptoms for 10 years, worsening, her pain's unbearable, like being hit by a truck. Her symptoms are worse at night, she's exhausted with activity. She does tell you she has swelling in her hands and feet, especially upon awakening. And she's 2 to 3 hours of stiffness. So she's giving you all these other buzzwords of information that I've described. So I would not fault you for checking an ANA in this patient. It's just they always come back positive in these patients. They always do. However, you know, an exam, this is where, again, the importance of the exam. In the end, she has normal passive range of motion of all her joints, and she anticipates pain, but once you're talking to her and examining her, she doesn't have any joint swelling or synovitis on exam. She has multiple soft tissue tender points, and the facial rash that she describes looks more like rosacea than a butterfly rash, and she doesn't have any hair loss. This doesn't show up well, but you know, they try to differentiate between inflammatory and centralized pain, and again, there's a lot of overlap in these things. So with inflammatory pain, it should be more localized to joints. With centralized pain, more diffuse. There's quite the constellation of symptoms that can be seen with centralized pain because you know this is a condition of hypersensitivity and every little bit of sensory stimuli being amplified. So you know, being aware of the bowels, mood disturbance, things like that. Stiffness in both of these scenarios, you know, greater than 60 minutes, but you should see objective swelling in the patient with inflammatory arthritis, and that's going to be absent in a fibromyalgia patient. We'll finish this up here soon. The ANA testing can identify about 150 antigens. Of that big subset that we know exists, you know, we only check a handful of these in clinical practice, and only a small percentage of them are known to be associated with autoimmune disease. Others are not of any clinical significance. I mean, high titers are more likely in patients with connective tissue disease, but you also see them in healthy controls, and it's not uncommon that I see, you know, an older patient who has a titer, you know, of 1 to 2,000, whatever, and, you know, is well and healthy and has no features of connective tissue disease. And in that scenario, I just say, you know, if you develop this, this, and this, give me a call and we'll reevaluate, but for now, you know, you don't have connective tissue disease. They mentioned in this study, in this article that we're reviewing here, this retrospective study of 232 patients that were referred to a rheumatologist for a positive ANA, and there was no ANA-associated connective tissue disease found in any of these patients who had an ANA of less than 1 to 160. So over 90% of the referrals for positive ANA didn't have any suggestion of ANA-associated disease, which gave it a positive predictive value of 9%, which is pretty lean. And the most common reason for ordering an ANA was widespread pain, and ultimately the conclusion was that, you know, this is ordered inappropriately for a lot of patients who have a low pretest probability of having connective tissue disease. So I always try to emphasize patients who I do see with this, that finding antibodies by themselves does not mean that you have a disease. The symptoms is what matters, and the symptoms are what is going to give you a diagnosis. Higher titers, you know, do increase your likelihood of autoimmune disease. That does not mean that I always find something. And in patients who I can't make the diagnosis, again, give me a call if you develop Raynaud's, if you develop joint swelling, if you develop rashes when you go in the sun. Those are a couple of things. Again, just driving home the point, some of these are slides that from my my ANA talk and labs from last year that I just wanted to close with. So over 1 to 160 is where I start to get interested. 40s and 80s, not uncommon in healthy normal patients. Our labs at Frater did not even flag these as abnormal, and they do here. And I think that creates a lot of anxiety in patients when they are told that that's abnormal, when it doesn't necessarily mean that anything's wrong. And then in the elderly, up to 70% of patients can have a low titer ANA. Osteoarthritis, just a couple things. Like I said, I can't see all of osteoarthritis. I do see plenty of it in overlap with other conditions that I see. The things that I try to remind myself not to forget about is that the benefit that physical therapy can bring to patients, I think, is immense, using assistive devices, braces if needed. Counseling on weight management is always hard to do, but a loss of 10% of body weight is associated with a 50% improvement in patients who have knee osteoarthritis and who are obese. For patients with isolated joint involvement, I do like topical diclofenac gel. It has similar efficacy in a lot of patients to oral NSAIDs, and it has a much better safety profile. Tylenol, always first line. There's not good evidence to recommend that, but if somebody's pain is controlled with Tylenol, there's not a lot of side effects that can go along with that. Oral NSAIDs, I think you have to be careful in who you're using them in. I see a lot of patients come to me on them who had an MI a couple of years ago and are on a scheduled NSAID, and they just can't do that. Topical therapies, and my favorite thing to pull out of my hat is Cymbalta. It's approved for the use of chronic musculoskeletal pain. I've seen it benefit a lot of patients, and I really like that one. Limited opioid use, if everything else fails and they can be used on a limited basis, there can be some benefit from that. And the cases that I gave you in the beginning, they were from these Room to Learn modules. If you go to the American College of Rheumatology site, they really have a couple of great resources that are meant for residents, primary care providers, people who don't do rheumatology. They're short, they're fun to do. It was enjoyable to go through them again. So that's it. Thank you. Any questions up here or after? If you guys want to stop by.
When someone talks to a gout, they have big toes and they don't like us to try to aspirate. Do you have any hints about that?
I infiltrate a lot of lidocaine and go for it. I'm always amazed at what people can tolerate with how bad that is, but plenty of lidocaine, just numb it up and you'll get a sample, and it really won't be that bad.
Do you always aspirate? If you have your textbook, this is, you've seen this 100 times, you know this is a garbage layer.
Yeah.
Do you always aspirate?
Almost always for podagra. Technically, if it is textbook podagra, patient has chronic kidney disease, you don't have to, but I also give patients the option, well, we can treat this flare right now, I'm gonna take some fluid out, prove it, and I will also put a steroid in at the same time. We'll keep birds with one stone. Thank you.